So one of the things, right before I introduce our speakers, I just wanted to comment that it's part of the inception of some of what we were doing tonight actually stemmed from some of our work with the Department of Health as part of our transition work and with Angie and the PA chapter of Family Physicians. We surveyed, and some of you that are here in family medicine may have actually answered that survey. We did a survey of adult primary care providers, kind of trying to ask some questions, identify adult primary care providers that might be interested in working with us and working with some of our pediatric partners in terms of accepting children with special health care needs, and asked a series of questions related to open panels, do they accept Medicaid, what kind of services do they provide? And one of those sections also asked about what diagnoses some of the healthcare providers would be comfortable taking care of as it related to adult primary care. And one of those diagnoses that was listed was autism. And by and large, we found that most of our adult primary care colleagues expressed that it was something that, adults with autism was something that they didn't have a whole lot of experience with. And we all know that, literally the prevalence of autism is increasing. And so we've been talking, and I had the good fortune of meeting Dr. Connell out in Philadelphia from the Drexel Autism Institute, and in talking with our team, we really want to, as part of our transition work, help to bring, and our learning collaborative, bring educational resources that, again, help both our pediatric and adult care providers, feel more comfortable and better equipped at taking care of, youth and young adults with special health care needs. So as such, and, in getting to talk with Jim, Dr. Connell, who I'm going to introduce, you'll hear today a little bit about some of the work that they're doing, which I believe is, on the cutting edge, and actually are already doing some work with adults with autism. And also with us on the phone that I'll be introducing is Dr. Brodkin, who's with us virtually. So how cool is it with technology that we're able to have him here, although he physically couldn't be here. He'll be here presenting as well. So let me introduce Dr. Jim Connell first. He's here to my right. He has a doctorate in school psychology. He's a nationally certified school psychologist and board certified behavioral analyst. He's worked at Penn School of Medicine, at CHOP, Center for Autism Research, and is now associate professor in the College of Education at Drexel, and a research fellow and director of the clinical core at the AJ Drexel Autism Institute. One thing that he has done is he's identified variables that influence adult behavior change in community settings, and does in getting to know Jim over the last couple of months, he's taught me a great deal. And really, if any of you are out in the Philadelphia area and you have the chance to come see what he and Dr. Newshafer have created at Drexel, the Drexel Autism Institute, it's pretty humbling and impressive. So he is also a project developer for the interdisciplinary case conceptualization model called Provider Agency Consultative Therapy, the PACT, that we're going to talk a little bit about here today. So it's really exciting and really grateful that you're here and you're partnering with us. And it's our hope that, working and educating around autism, that this is, the first of many educational opportunities that we have. I'm also going to introduce Dr. Brodkin, who's on the phone, who's the founder and director of the Adult Autism Spectrum Program at Penn Medicine. He's an associate professor of psychology at the Perelman School of Medicine and at Penn. He has done his training at Harvard and at Yale, was chief psychiatry resident at the Clinical Neuroscience Research Institute at Yale, and he's been involved in the clinical assessment and care of adults with autism spectrum disorder since 1995, and has done some really interesting work and working on the treatment plan and development implementation and on the coordination of behavioral, the medical and psychological care of adults with autism. So we're really lucky to have both of you here with us tonight. So thank you for being here.
Okay, thanks, Renee. I really appreciate the introduction and the kind words. I'm really, really excited to be here today because we've been doing at the Drexel Autism Institute and the ASERT Collaborative some really, really cool stuff, and we're happy to share that with folks in the state and even across the states. We're going to do a couple of different things today. We're going to provide a brief overview of the ASERT, talk very briefly about what is ASD, although we could spend more time on that if there are questions, especially as they pertain to the adolescent and adult presentation of ASD. Perhaps discuss some ways that we can think about assessing ASD in adults, and then talk about some intervention models that we're developing. So let me see if this thing works. Okay. Can you guys hear me? Oh, good. So I'm a kinesthetic sort of thinker, so I got to move when I'm talking. It helps with the process. There's a couple of things that I want to do today. I want to talk about the ASERT, because the ASERT is really, really important. I'll explain what that is in a moment. But I also want to talk about what care coordination and services look like for the adult population. And so, as many of you as you know, birth through 21 is covered through IDEA. And if you have an ASD diagnosis and no other comorbid mental health or intellectual disability, services after 21 are non-existent. They really are. They fall off. You can have the ACAP or you can have the waiver. There are 550 slots for ACAP and waiver in the state of Pennsylvania. The need is tenfold. And we'll talk about our census data in a minute. So there are waves of children leaving the education system, being served in primary care physicians' offices, leaving the education system with virtually no support for behavioral health, mental health, jobs specialist training, occupational therapy, speech therapy. Virtually services drop off to next to nothing. And there's some data on that, actually quite a bit of data now, by a fellow by the name of Paul Shattuck, who has done some research, who is now a program area researcher at the A.J. Drexel Autism Institute, whose primary interest is looking at life course outcomes across the autism spectrum and identifying where the service gaps are and where the disparities are in services according to developmental group, and in particular in relation to ASD. So we're doing some really cool work sort of charting where the gaps are, and also through the ASERT, trying to address those gaps. So the ASERT is the Autism Services Education and Resources Training Collaborative. Are you guys familiar with that? Yes and no? No. Many no's, some yeses. The ASERT is a collaborative. It's a grant mechanism through the Bureau of Autism Services, which is a bureau in the Department of Public Welfare in DPW. And when they first started the ASERT, I think in '08, it was really a grant mechanism that had an RFA that went out that universities responded to. And there were 3 at that time. Penn State Hershey had one of the ASERTs. They still do. Western Psych had one of the ASERTs. They still do. And at the time, the Eastern ASERT was at Penn, which is where I was at the time. It has now since moved to Drexel. The director at the Eastern region is Lindsay Lauer. She is a PhD candidate in public health, and I am the clinical director. The Central region, Amanda Pearl and Mike Murray at the Penn State Hershey Medical Center, some of you may know, are the Eastern or the Central region directors, and John McGonigal out at Western Psych. Many of you may know him as well. So, so it's a grant mechanism that sort of has developed into a contractual arrangement with the BAS and the ASERTs, because there's a negotiation around what the projects are out of each one of the ASERTs. And what guides the ASERT projects was the first round ASERT Pennsylvania census data, which I'm going to show in a minute, as well as the needs assessment. So just some quick, I'm sure that many of you are familiar with the recent CDC report. Autism prevalence now 1 in 68. The male-to-female ratio is still 5 to 1. 1 in 42 boys, 1 in 189 girls. So just by show of hands, how many of you either know a child with autism or have served a child with autism? Everybody? Mostly everybody. Everybody. When you look at the trend across time, you can see from this CDC data, the number of sites, as well as the increasing prevalence from 2000 to 2010. It's growing at an alarming rate. The prevalence is increasing at an alarming rate. And right now, those waves of students, as I said earlier, are moving through the education system, and they're leaving that. And they are leaving the education system in waves. And the number of students, the number of children who are going to get diagnosed is only increasing. And this is validated by a policy brief that I think that we're going to put out through the Autism Institute. Over the last year, the Autism Institute has been engaged in some community outreach. And the community outreach has meant that we've gone out into the community to approve private schools, other private schools, the public school systems, in an attempt to develop a relationship with those community partners to either expand our services and disseminate evidence-based interventions, or to perhaps encourage some of our community partners to engage in some research with us. In every one of those schools or clinics that I visit, I ask, what has been the difference? How have you seen your demographic population change over the last 10 or 15 years? And 15 years ago, the population that they served, the developmentally disabled population that they served, was broad. There were children with emotional behavior disorders, specific learning disabilities, Down syndrome, Fragile X, and ASD. And the ASD portion of their population 15 years ago was maybe 20%. And if you go back to those same schools now and you ask them, what is the percent of the population that you serve that are diagnosed with ASD? Every one of them is reporting 75 to 80% of their children are diagnosed with ASD. And the number of children with Down syndrome has decreased dramatically. And the number of children with emotional behavior disorders that they're serving has decreased dramatically. Specific learning disabilities, many of those students are being pulled back into the district. I'm not exactly sure where all the Downs children are going, but they're not being served in these institutions any longer. 75, 80% are ASD. And these schools are full. They're at capacity. So we did a census project in the first round of the ASERT. The ASERT has now had 2 rounds. There are 2 RFAs that went out. Penn responded to the first one. We did the census project back then. Drexel responded to the second one. We now have the ASERT in Drexel. In 2005, the largest group was the 5 to 12-year-olds. So if you fast forward 9 years, this group is now 21 years old. And they're leaving the education system, and they're entering the mental health and behavioral health world. In the best case scenario, they're getting into mental health and behavioral health clinics. The worst case scenario is they're sitting at home on mom and dad's couch, can't find a job, have no services, and mom and dad are 65 years old, and they're wondering what's going to happen to my kid. And we hear this all the time. It's a significant concern. This data is now being updated. At the time that we collected this data, we were only able to get Medicaid data to identify individuals with autism spectrum disorder. We have gone back to the education system, back to private insurers, to Medicaid recipients, and have even contacted the juvenile justice system and the justice system. And we have an updated census report that's coming out that shows that right now there are closer to 30,000 individuals in the state. When we had this first estimate, it was Medicaid data only. And these were our projections up until 2050, where it looked like maybe there would be 19,000 with new diagnosis. And with no new diagnosis, 15,000. We already know that data was an underestimate and perhaps a gross underestimate. If you look at the prevalence, actually, where it was 1 in 88, and there are 13 million people in the state of Pennsylvania, there are roughly 140,000 people potentially in the state with ASD. We're capturing, in our most recent census data, about 30,000. After the census project, we did a needs assessment. For all those folks that we could identify through the census project, they got a needs assessment survey. And the needs assessment survey asked a whole bunch of questions, a lot of questions. you could find the reports of the needs assessment and the census data, not only the reports that are going to be coming out in the next couple of weeks, which is going to update all this information, but the reports that we published back in 2010 and 2011 around need. You can find them on paasert.org, paasert.org. I would strongly encourage you to take a look at that website. There's an invaluable amount of information on that website. Yeah.
Is this kids that just strictly have the autism diagnosis, not dual diagnosis?
No, they could be dually diagnosed.
So they could fall in the MR category and have autism?
Yes. Yeah. So ID, autism, OCD, autism. Yeah. Some of the things that we asked about were, as you enter into adulthood, what are your needs around transition planning, career counseling, vocational training, and supported employment? And a vast majority reported that it was either an unmet need or they were dissatisfied with the services that they had. There were very few who reported that it was a met need and that they were satisfied with the services. In the most recent census data and needs assessment, what we are seeing without effective supports is a growing number of individuals on the spectrum who are homeless, who are being placed in inpatient treatment facilities as a result of crisis. By the way, that crisis intervention, those 3 and 6 month stays in crisis centers are costing the Pennsylvania taxpayers an exorbitant amount of money. I submitted an R34 to NIH looking at testing a model that would decrease the cost by providing a different type of service that would prevent crisis need. And in the data that I looked at to report the cost, which a number of people have done, it's approximately $137 million per person across the lifespan. So then if you then times that by that cohort, the number is incredible. I think $35 billion across the lifespan for a cohort is what the American taxpayer is paying for supports like six-month inpatient treatment facilities. It's an incredible cost. We're seeing an increasing number of hospitalizations. And those hospitalizations oftentimes lead to inpatient treatment. So way back in the early 90s, I worked at CHOP before I went on to graduate school in a place called the Biobehavioral Unit. The Biobehavioral Unit at CHOP was modeled after the Kennedy Krieger Neurobehavioral Unit. At that time, there were probably three sites like that in the country. There was Kennedy Krieger's site, there was CHOP's BBU, Biobehavioral Unit, and one on the West Coast. There are a few others now. Marcus Institute in Atlanta has one. Kennedy Krieger still runs the MBU. Bancroft in Haddonfield has one. Of course, Western Psych has one. They all operate somewhat differently, and they all incorporate different types of services differently as well. Some of them are pure medical model, and pure medical model oftentimes results in medication treatment packages without additional treatment packages. So the BBU at CHOP regrettably closed in 1998 or 1999, somewhere around that time. And since that time, a city as large as Philadelphia does not have a treatment center, either inpatient or inpatient and outpatient, to stabilize kids in crisis or adolescents in crisis and transition them back into the home or into their natural placement, not right onto an inpatient facility, a long-term inpatient facility. The city no longer has the capacity to do that. And in fact, and somewhat disappointingly, when I was at Penn a few years ago, I got called in on a case where a 14-year-old boy was in an ICU unit, and he had autism spectrum disorder and significant aggressive behavior. And whenever the staff there tried to treat him, he would become aggressive. He would kick them and hit them. And they would end up using some kind of medical restraint to subdue him. And so this guy spent a year in an ICU unit in Children's Hospital of Philadelphia, snowed, because they couldn't figure out how to work with this guy. And they called me in because of my experience back on the biobehavioral unit back in the mid-90s. Susan Levy at the time said, and the reason that they called me in, I hesitate to say this out loud, they were thinking about pretty invasive procedures to use with this fella. I'm not going to describe what they were, but the chief medical officer contacted Susan Levy, who contacted me and said, we've got to figure out a way to develop a treatment package and train the staff for this child. Otherwise, they're considering a pretty invasive procedure. So we see that there is a significant and growing need in developing interdisciplinary treatment models for this population. And I think in many ways, we may have even taken a step backwards from where we were some time ago. So we see an overuse of chemical restraint. We're seeing increasing contact with the juvenile justice system. When we first did our census project and our needs assessment, there were very few at that time, just 5 years ago, of adults on the spectrum who are identifying as having a substance abuse issue or coming into contact with the juvenile or the adult justice systems. And right now, the trend is an upward slope, and a significant upward slope, of ASDs coming into contact with juvenile justice and the adult justice systems, while the general population is on a downward trend. There's a divergence. ASDs, drug use, smoking behavior, alcohol use, and contact with the juvenile justice system are all on the rise. And that used to be a way that we could discriminate in the adult population between adult presentation of ASD and things like schizotypal personality disorder or schizophrenia. So individuals, adults with schizophrenia, oftentimes have smoked, have used illegal drugs, have drank alcohol, and have had contact, generally speaking, with the justice system. And so when we did this project in the Norristown home, we used those as identifiers to try to screen for who might be in the Norristown Center with ASD that was misdiagnosed as schizophrenia. And we can no longer use those markers as indicators of the presentation of ASD rather than schizophrenia, because we're seeing an increasing rise in the use of those or the contact with the justice system. All of those, of course, produce high family stress, right? Mom and dad are stressed with, and I work in the home right now on a Department of Defense grant on a sleep study with Margaret Souders, who's a doctor of nursing at Penn. And we're out in the home helping parents develop tailored behavioral interventions to help their children sleep through the night, to decrease their sleep latency and their insomnia. And so, I've been working, I'm an academic at a university, but I've been very clinical all through my time. And I'm out in the home working with parents, and they are stressed, and they have been stressed for a long time. And unfortunately, there is a growing trend with these individuals, and especially adults, living at home, on mom and dad's couch, playing video games, and having very little quality of life as it pertains to social interaction, activities of daily life, having meaningful employment. Right? We're seeing just so many 25-year-olds and 26-year-olds and 30-year-olds really struggling with life. So a little bit more about the ASERT. Our goal is to develop services across the state of Pennsylvania that get to all areas of the state. It's interesting that when you live in Philadelphia, you think the state's like Philadelphia. 46 of the counties are rural, and I'm reminded of that every time I drive out here to Penn State, that there's an awful lot of farmland in between Pittsburgh and Philadelphia. And then in the northwestern part of the state, it looks very different than the rest of the state, and so does the northeastern part of the state. And there are individuals with autism in every one of these counties. And the amount of service that they have in those counties differs significantly by a number of different things, including the service providers who are out there, and the training of the service providers who are out there, and the accessibility of their care coordinators, their supports coordinators, their case managers, and just the overall availability of any kind of service. So Philadelphia doesn't have a known clinic for the assessment and diagnosis of adolescents and adults on the spectrum. They have RAC, the Regional Autism Center at CHOP. The wait list is a year. They have St. Chris. And by and large, what happens in a lot of these centers is that you bring your child in after being on the year for on the wait list for a year, and they do an evaluation, and it's usually a very good evaluation, and you get a page of information about your child's diagnosis, and the parents have no idea what to do with that information, right? So they get a page of information saying your child's got autism, and what to do after that. There might be some brief counseling provided by a social worker about where to go for services. You need to go to Elwyn and get your child registered for early intervention, contact medical assistance, and sign them up for medical assistance. Your child needs behavioral therapy, get a behavior analyst, and that's the recommendations, right? And parents have no idea what to do with that information. So, out of that needs assessment and out of the understanding of the landscape over the last couple of years that we've been working on these projects, what we've done was to reach out to community-based providers to help understand how to build these services, how to build the pathways to these services, and how to build the services, not only for the adolescent population, but also for the adult population, paying in particular mind to the adult population, which is not to say at the exclusion of the child population, but there are places where the diagnosis can occur. There are EI centers. There are good things happening in public schools. There's nothing happening post-21. Except, I think, the work of the ASERTs. So I don't want to sort of review what you already know. The DSM-5, social interaction and social communication deficits are a common or a core deficit area for individuals on the spectrum, and restricted and repetitive patterns of interest or behavior. What's interesting about the adult presentation of ASD and the potential misdiagnosis and then follow-up treatment packages is that if I'm doing this and I'm an adult and then I'm scripting, that's my favorite movie, that was a really good movie, I like that movie, that was a good movie, that was a good movie, I like that movie. Those folks as adults in mental health centers can be misdiagnosed as schizophrenic. Not can be, are. Happens a lot. And so they're misdiagnosed, and what looks like is happening is that there are delusions or hallucinations because they're scripting and they're rocking. And so what's the prescription? An antipsychotic. And then the antipsychotic doesn't work because they're not hallucinating or having delusions. They're scripting. It's a symptom of ASD. They're engaging in a restrictive, repetitive pattern of behavior. And then you try to talk to them about what they're doing, and they can't have that conversation back with you because there's no reciprocity, so they can't tell you what they're doing. And so their speech seems disrupted, disjointed, and they can be easily, and are easily, misdiagnosed as schizophrenic. In fact, we found 10% of the folks who were diagnosed with schizophrenia in the Norristown Project were adult presentation of ASD. That's a pretty high percentage. So we'll go through this quickly. I'm sure that you're all familiar with this. Lack of attention to faces. Have extreme difficulty recognizing emotion on a face. If you're happy, it's hard to recognize. If you're sad, it's hard to recognize. If you're cross, it's hard to recognize. If you're being sarcastic, it's hard to recognize. If you're engaging in humor, hard to recognize in the adult and adolescent population. Significantly reduced eye contact. A lot of times you get that eye contact out of the corner of the eye. You know, they look at you out of the corner, and so they're looking at you, but it's out of the corner. It looks a little odd. Social emotional reciprocity. How are you doing today? Fine. I'm fine too. What's your name? John. My name's Jim. Right, so they lack that social reciprocity. Difficulty in perceiving, responding appropriately to and expressing emotions. 0 to 60, in 5 seconds. They're engaged in some behavior. Perhaps they're getting frustrated, and you go from frustration to self-injurious or aggressive behavior like that, and that oftentimes gets diagnosed as an explosive aggressive disorder or something like that. And then when it's diagnosed with some type of explosive disorder, there's usually a medication prescription to resolve that issue, when in fact, the treatment choice might be to build communication skills, to build functional communication, to learn to express when you're frustrated or upset, that there's a way to express that and to get your needs met. Boy, that's a really nice blouse. I like your haircut. So in the hidden curriculum, that could mean, I really like your blouse, or, oh my God, where did he or she buy that blouse? It's horrible, right? Are you familiar with that? So, so the hidden curriculum is understanding the nonverbal social cues, or the verbal social cues, social cues, that may have one or more meanings. And in grades 1, K through 5, kids are real honest. So they say, oh my God, your haircut's horrible. In 6th, 7th, and 8th grade, it gets a little bit more subtle. Who cut your hair? That looks kind of silly. In high school, it gets much more sophisticated. In college, even more so. As adults, displeasure, disapproval, rejection, especially in the academic world, is much more subtle, right? It's much more subtle. And you could be stabbed, in the chest with a smile on the face of the person who's doing it. And if you don't understand the social cues there, you miss everything. You miss it all. And when you make the mistake, when you make the social cue mistake, then you oftentimes get dismissed or ignored. And so adults on the spectrum have a really, really difficult time understanding the hidden curriculum and the social snafus that they make. And so they find themselves isolated because they say things that they shouldn't say in contexts that they shouldn't say them to people who don't want to hear that. I like the way you smell. That happens, right? It happens, and it happens a lot. It happens in college. They're right up on you. And they want to have a conversation with you because he's a male, and he's at college, and there's a pretty female, and she smells good. And so they walk over and touch their skin, or smell their hair, and say something that has no chance of ever getting a date, right? That's done. That poor fella has made a horrible mistake, and he doesn't even know it. So you have a failure to develop peer relationships appropriate and at the developmental level because of the hidden curriculum, because of the social cues that are missed and are unknown, and then the inability to engage in them. So as children, we see absence of language or delayed language development, stereotypical repetitive behavior, use of idiosyncratic language, idiosyncratic language, and echolalia, single words to communicate. You're all familiar with this. Or are you? Lack of spontaneous, imaginative social play appropriate to the developmental level. When we do our ADOS assessments, the gold standard for the assessment of a child with an autism spectrum disorder, you take a car, a blue car, and say, this is a rocket ship. Shh, look how cool my rocket ship is. You do that. And they say, this is a car, and this is a car, and this is a car, and they stack them. All right? Pretty clear indication that they lack imaginative play appropriate to their developmental level. One of the ways that you diagnose using the ADOS, looking for symptoms like that. Impaired ability to initiate or sustain a conversation with others. ABA as the preferred treatment and most evidence-based treatment approach for individuals on the spectrum does really, really well with skill development and problem behavior reduction. But there's so much more to do. For example, initiating and sustaining a conversation. So if you're a behavior analyst, you might teach an approach, we call it an approach response. Hi, my name is Jim. And then they shake your hand and you teach them to say, hi, my name is John. And so every time they meet somebody, that's what it sounds like. And so you see a lack of generalization around the different type of response types. Yo, what's up? Hey, how you doing? Or, if it's the principal of the school, hi, Mr. Principal. There's a lack of generalization and a lack of recognition of the social cues to indicate which type of greeting is appropriate in which setting. Tone of voice. I had this guy that I work with at CHOP. I love this guy. His name was Mike. And CHOP, in the Bauer Behavioral Unit, we used to treat severe aggression, self-injurious behavior. And Mike was a 16-year-old who I could just go on and on and on about. He was so cool. But when Mike became aggressive, he would tell you, and he would use the same tone of voice that he used everything else, and he'd say, "I'm gonna hit you now," and then he'd swing at you like that. And every time he talked, he spoke like that. Interesting fella. A lot of fun Mike was. Is all of this just review for you guys? No. No and yes. A little bit of both. Okay, so I'm trying to not skip over things that you don't know, but I don't want to bore you with things you do. And feel free to stop me at any moment if there's something that's on there that I didn't explain that you want to know more about.
I have a question.
Yes.
You were talking about autism that presents in adulthood. Is that just someone that's been overlooked, just misdiagnosed or not diagnosed?
Yeah. Yeah. Between the ages 10, 15, 20 years ago, our tools weren't as sensitive as they are now, and our surveillance wasn't as pervasive as it is now. And the tools that they used, I think, oftentimes could underdiagnose, especially as it pertained to the severe and profound range of ID. So we weren't looking for, or the symptom presentation was so similar in a severe and profound range of ID that they never got diagnosed with an autism spectrum disorder and an intellectual disability because the symptom severity was so complicated. And if we didn't have the sensitive tools, which at 15, 20 years ago we did not, they would oftentimes get diagnosed with an intellectual disability, not necessarily driven by the symptom presentation, but could be, but oftentimes driven by where the services were available. Right? So services are available for the ID population, but they weren't available and still are not in many cases for the ASD population. So if it looks kind of close, let's call it ID. Let's call it MR. And so that's the diagnosis that they would get, and then they would keep that through the rest of their years. There's a lot of really high functioning folks. Hi guys, how you doing? I'm just going to draw attention to you since you came in late. Yeah. Oh, I'm sorry. Oh, it's my fault. Yeah. So the other kids who got missed were the kids that were odd or quirky, right? They didn't have a lot of friends. Oh, he's just odd. He's just quirky. They could keep up academically because a lot of the less impaired. I don't like to use high functioning or low functioning. The problem with high functioning and low functioning is that when you say that, you offend the other group. So we're really trying not to say high functioning and low functioning, and it's also difficult to identify what makes them high functioning and what makes them low functioning, when in fact some of the kids who are diagnosed as being low functioning have incredible skill. They've learned to manipulate their environment very, very well, and so you could sort of just. So in terms of social and communication impairment or the absence of an intellectual disability, you see many of the folks who have very little impairment. have 160 IQs. They're really, really bright. And academic material is simple for them. Really, really, and a lot of those folks move on to college and do quite well. Some of them even get married, something that we've seen actually quite a bit. Get married, and then at 35 or 36, the wife is bringing her husband in tow into an adult assessment center saying, there's something not right here. Like the connection's just not there. And he doesn't seem to care really about me one way or the other. I mean, I know he does, but we can't get over this thing. And so, I mention these not as anecdotes, but as actual cases of the adult presentation. And so kids like that went through the public school system as being called odd or quirky. But academically, they kept up. They had great communication skills. Their social behavior, which is I think the really core way that you can really identify some of the less impaired folks. They still have the social reciprocity deficit. When you say, how are you? How are your children? You might get a response, but it's not going to be reciprocal. You rarely hear, even from the very minimally impaired, I'm fine, how are you, in a very natural to and fro of conversation. And that's one of the things that I look for, especially in the adult presentation. Where is the reciprocity? How much to and fro in conversation is there? Or when you initiate a conversation, do you get some initial to and fro, but then it's right off into a preoccupation with a specific interest? They just want to talk about their job. They build airplanes, and they built this kind of airplane, they built this kind of airplane, and this piece goes into this part, and they've got the whole Boeing 747 memorized, and that's all they want to talk about. And so then you start to sort of, try to divert the speech, divert the conversation, and it just keeps going back into the area of interest. Yeah.
I remember when I was in medical school, and they brought in a child with autism for us to see. It was a 7-year-old, and she went up and down the aisles, focusing the
Yeah.
And they said, this is what autism is, period, end of discussion.
Yeah.
And everybody else was either schizophrenic or quirky.
Yeah.
And I'm wondering, as we've evolved through that to pervasive developmental disorder to
Autism.
the word
Yeah.
autism, how has that impacted the statistics of who's autistic? Is it really, really that big an increase, or are we switching some diagnoses?
So I don't know if we're switching diagnoses. I think ASD has been around, and I think it's been around in large number. I think there are folks at the Drexel Autism Institute, like Craig Newshafer, who's the director of the center, who's an epidemiologist, who's looking at how environmental variables could, in fact, lead to some developmental effects on the fetus. And so he's collecting all kinds of environmental samples, including a 20-week sample of mom's blood and the blood in utero. I'm not a physician, so if I screw things up, don't shoot me. And then they're also going into the home, and they're looking at all the chemical agents, all the cleaning solutions, the diet, what they drink, what they eat. They're getting swabs of dust off of countertops and TV tops. And then at delivery, they're getting a sample of the umbilical cord blood as well as the placenta. And so there are folks who are looking for, is it possible that there's an environmental?
They're looking at noise also?
I don't know if they're looking at noise. I saw a really interesting thing in the paper the other day about the chemtrails. Did you read that on NPR? It's really, really interesting. So they're looking for which apparently has aluminum in it in this most recent report. And so they're looking for the presence of heavy metals. I don't know where that research is going. I think that our surveillance has gotten more sensitive and our tools have gotten more sensitive. And I think that in part has led to a significant increase in the diagnosis. But I think that there are other variables that are increasing the incidence as well. And we haven't figured out what those are yet. How am I for time? So just Some quick data, intellectual disability, about 40% of individuals on the spectrum have an ID as well. There are other more subtle cognitive features, especially around executive functioning, planning, reasoning, the ability to understand abstraction or vagueness in speech. We see sensory, motor, memory, and language concept formation deficit areas. There's a really cool study that I was doing at CHOP with Bob Schultz around the reward circuitry of the brain. And what he was looking at, using fMRI technology, they were using a video display that had an array of 50 objects on it. And that array of 50 objects included things like mom and dad's faces, bicycles, examples of technology, either an iPad or a computer or something like that. Food objects, drinks, preferred things to eat. So an array of 50 objects, and using an eye tracking device, what they would look at, and what they would find is that individuals on the spectrum looked at examples of technology and other preferred objects way more often than they did the pictures of their parents' faces, which they rarely looked at. And in comparison to a typical group, the neurotypicals looked at mom and dad's faces first, and then other faces with facial expressions before moving on to the other objects in the array. And at that, and then using the fMRI technology, you could see where the reward circuitry in the brain lit up when they looked at these different things. And the reward circuitry in the brain did not light up in the ASD population in the same way it did for the neurotypical population when looking at mom and dad. So when you ask about sort of where is this deficit area in terms of the reciprocity, the social reciprocity, there appears to be some evidence that there's a structural difference in the brain, especially in the reward circuitry. So seizures, 30% on the autism spectrum, happen both in early childhood and adolescence. And we are seeing a growing number of individuals on the spectrum who are diagnosed with an anxiety disorder, OCD type behavior, and depression. Yeah, it's actually quite high. The data on the anxiety disorder in ASD is really interesting because there's been a number of studies that have been published, and I think it's anywhere between 11 and 80% depending on the publication that you look at. So there's still a lot of work to be done in that area, but it could be as high as 80% have potentially have an anxiety disorder. I think part of that problem is they're using anxiety disorder rating scales for a neurotypical population and getting symptom overlap on the scales. You have a child or an adult, an adolescent who has very little functional communication. They engage in a lot of echolalia, but have very little functional communication, especially as it pertains to an expression of their wants or needs. And when those wants or needs are not met, when task demands are greater than they can tolerate, and there's a high frustration level, and they can't express, I'm all done, I can't take this anymore, please allow me to escape this. You see a significant amount of tantrum behavior, aggressive behavior, and self-injurious behavior. And the self-injurious behavior that I have worked on, that I've treated at CHOP, is traumatic as a clinician to treat. I spent 3 years on a self-injurious behavior study grant where we were looking at different medical treatments for the occurrence of self-injurious behavior. And so for 3 years, I treated kids who did the most amazing things to themselves. That after 3 years of that, I actually got out of this field for a little while because it was traumatic. These kids were picking the skin off the back of their hand, and they would have these huge holes in the back of their hand, right down to the tendons, hitting themselves in the head so hard that they detached their retinas, big, bulbous sort of contusions on their head and on their brain, unfortunately. This one little boy that I used to work with picked all his fingernails off. He had no fingernails at all. He picked all his fingernails off. And then he would pick them off, and it would get to a point where it would become bloody and really hurt, and he would cry, and he'd come over to me and cry, and then once the pain subsided, he'd go back to picking his fingernails off. Really, really traumatic stuff. And so the occurrence of self-injurious behavior, as a matter of fact, I was in a home last night with a boy who's pretty impaired. He's 280 pounds because mom and his sister have a hard time tolerating his aggression. And so whenever you place a task demand on him, he becomes aggressive, and he wants to eat and sit in front of the TV and watch his favorite shows. And so he's 10 years old and 280 pounds. And they have spackled over all the holes in the wall and have stopped issuing demands, which any kind of request. It's time to put your clothes on now, right? That's a demand. It's time to eat dinner now. It's time to stop eating dinner now, because he hurts them. He's aggressive, and without and he's 10, so he's going to hit 13, and then there's going to be hormonal changes, and he's going to start developing muscles, and mom's not going to be able to keep him in the home. That poor fellow is on his way to a residential placement, and then he becomes an adult. And part of the reason that we developed this interdisciplinary case consultation model is because those are the folks that we're seeing in the mental health system. Those are the folks that we're seeing. And the services that are available to those folks through the service providers, I think are focused on one area. You can reduce the occurrence of self-injurious behavior to a certain degree with some medication, but medication in the study that we did and in the medications that they developed since then rarely reduce the self-injurious behavior in any significant way. You can get a statistically significant decrease, but if you go from hitting yourself 100 times in the head per day to 50 times in the head per day, that's statistically significant, and it's not clinically significant in any way whatsoever. And so the model that we're trying to develop, and I'm going to talk about in a minute, is a model where the medical home, wherever that may be, uses their behavior analyst to help develop a treatment package with medication and behavioral therapy through the presentation of a graphical illustration of the target behaviors to develop a comprehensive treatment package that has the ability to demonstrate through data collection whether or not the medication and the treatment and the behavioral treatment package are reaching a clinically desired effect, whether or not there's a reduction in the aggression or the self-injurious behavior. So I put this guy through a couple little tests because I wanted to see how bad his aggression was, because I needed to see how bad his aggression was, so that when I started making treatment recommendations to mom, I had some idea about whether or not she could do it. So I spent 3 minutes asking this guy using 2 different PEX cards. Are you familiar with a PEX card? A PEX card is a symbol on a laminated piece of 2x2 paper. And the symbol on that piece of paper is something that child or adult, whatever the case may be, may want. A drink, a food, an object, a person. And so for those who are non-communicative or have no vocal behavior, they would hand you the PEX card as a form of functional communication to get the things that they want. So I'm doing this very, very simple PEX training with them. He's got 1 drink card and 1 eat card, and I'm saying, hand me the drink card. And so he just picks any card because he has no functional communication yet. He can't. He engages in echolalia, so he has a voice and he can talk, but the services haven't taught him how to be functional in his communication. So despite the fact that he can say drink and eat, he doesn't use those words functionally, and he doesn't know the difference between the 2 symbols, even though he's got a PEX system. So that's a problem with the behavioral therapy that's going on. So I asked him to hand me the drink card, and I put them down in front of him, and I switch position for 3 minutes, and he swats me. And when this guy I weigh 170 pounds, he's 280, and he did this, and I went back on my heels, and so I said, okay, I got a good idea about what this looks like, but I've done this before, and I've done this a lot, and I've done it with folks that are this big, and so I needed, I had to press because it was important to see how bad the aggression got, and whether or not there was a response hierarchy. A response hierarchy is they engage in one behavior, that's functional to escape the interaction. And if that behavior doesn't work, then they move on to the next behavior. And those behaviors would make a response class, and they oftentimes occur in a hierarchy. You'll see the occurrence of one first, followed by the next, and they oftentimes get more severe. And so usually you see some tantruming or whining behavior, go away, right? That doesn't work, swat, because it doesn't hurt them. And when that doesn't work, self-injurious behavior. And sure enough, 2 minutes later, hit his head, bit his hand. Self-injurious behavior. And at that point, I saw what I needed to see. Now I've got a real understanding about what mom's dealing with. And now I know why he weighs 280 pounds and why mom's reluctant to put any interventions in place, because she can't tolerate it. It's going to be too much. So there's a lot of tantrum, aggressive, and self-injurious behavior in this population because they lack functional communication in many of these kids and adults. There's a lot of hyperactivity and ADHD-like symptoms. I think ADHD gets diagnosed quite frequently in this population. I also think that symptom overlap, but perhaps not entirely. I think Ted's going to talk a little bit more about medications. A small percent have savant-like skills. Those are pretty interesting when you see them. I had a fellow who would look at a map once, and then he would draw the map over and over and over again. And he could draw a very, very detailed map. Elevation, state flower, state capital, state bird, state motto, and he would just draw it over and over and over again. That fellow could get a job. He could get a job, right? If we start thinking about what the jobs are possible, what the job possibilities are for him. We see an enormous amount of sensitivity to sensory stimuli, including hyper and hyposensitivity, also to pain, but specifically around sight, smell, touch, taste, and I get them all? Yeah. One of the things that we did at the Autism Institute is we installed LED lighting, because there's a lot of anecdotal report, very little evidence-based research so far, but we have a project to test that fluorescent lighting is a sensory stimuli that overwhelms many individuals on the autism spectrum. It flickers, it hums, and it casts a specific wavelength. And that actually bothers a lot of people, not just folks on the autism spectrum, me being one of them. And sleep difficulties. The Department of Defense grant that we have is a Department of Defense grant to look at, I think the age range is 6 to 14, to look at developing tailored behavioral interventions based on the Autism Treatment Network Sleep Toolkit, but then modifying that for a parent in the home to address sleep latency and insomnia. Some of these kids are getting 6 hours of sleep a night. Want to know why they have ADHD symptoms? There are 6 hours of sleep a night. Ted's going to talk about pharmacological interventions. Do you guys know, does everybody know what the prescribed treatment approach is or should be for a child or an adolescent on the spectrum, an adult? Applied behavior analysis, ABA. The National Standards Report in 2009 published a study. They started off with over 4,000 evidence-based interventions. They took a very, very stringent inclusion, exclusion, methodological criteria. What counts as good research? And they applied that to the more than 4,000 studies that they found looking at PubMed and PsycInfo and the other web-based journals, and came up with 775, I think, studies around the use of intervention for those on the autism spectrum across the lifespan. And in that report, 75% of the studies were from the field of applied behavior analysis. 75% of the 775 studies that were included in that study from applied behavior analysis. Of the other 25%, 2/3 of them were behavioral in their approach. Applied behavior analysis is the therapeutic recommendation for kids on the spectrum. There is no disputing that at this point. You can look at Educating Children with Autism, that book that was written by researchers from across the country. There's a recent publication that just validated the National Standards Project. These are works that are not published by behavior analysts, but by people who are looking at the research and saying, where are the evidence-based therapies? Chelation therapy, not one of them. Hyperbolic chambers, not one of them. Sensory integration therapy, not one of them. Other dietary types of interventions, not an established intervention. So we took all this information from the Pennsylvania census, the needs assessment. I have probably 20 years at this point serving individuals and families on the spectrum, beginning in 1994, 1995 at Children's Seashore House, where the biobehavioral unit was located. Looking at the reduction of services that we've seen over the last 5 years, and the absence of services for the adult population. And as part of one of the Eastern Region's ASERT projects, we developed a consultative therapy model for provider agencies. And this is, I think, really a stopgap measure, because there are no services out there now, and there are no service pathways out there right now. So what we're doing in the provider agency consultative therapy model is identifying where the need is. It's in mental health and behavioral health centers. It's in hospitals. It's in clinics. We're identifying where the model would be located. At first, I thought, as a behavior analyst and a psychologist, that attacking this from my discipline was perhaps the way to go. But we're not just trying to develop services. We're also identifying policy and funding for the services, because you can have great services, but nobody's going to pay for it, then nobody's going to get them, right? So at first I thought, well, if I can get all the behavior analysts in the state, there's only 400 of them, maybe 500 at this point, so that's not going to work. All the behavior analysts in the state, I've trained a lot of them. Some of them are good, some of them not so good, right? So, and that's with any discipline, right? You've got really good behavior analysts, and you've got some behavior analysts, not so good. So that approach probably is not going to work. There's no funding for it. I can't get you guys to listen to them. They're not in your offices. You probably don't even know that they're out there, or that the parent has one. Right? In many cases, lots of folks don't know that behavior analysts are working in the home or working in the school with the child that they're seeing. So that approach wasn't going to work. If we go to you and say, there are these folks out in the field who can help you evaluate the intervention recommendations that you make by giving you data to demonstrate whether or not the recommendations that you make with them, right, a combined pharmacological and behavioral approach, obtains the desired outcome, then I'm much more likely, I think, to develop the funding for it. Oh, by the way, there's funding for it. If you submit to the insurance companies a significant amount of data, graphical presentation of the effects of the pharmacological intervention with some behavioral intervention, insurance companies will reimburse you at a higher rate. So the system has an incentive system built into it, and it's through the physicians. You can say to mom or dad, do you have a behavior analyst working with you? Have them track this behavior. Have them graph and track this behavior and bring that data into me the next time that they come into this, the next time they come in here. Or perhaps if there's time, which there's not, but ideally if there was, have a conversation with the behavior analyst. Have the behavior analyst come into the appointment with you or with the parents. Can you bring your behavior analyst in with you to the appointment? So we could talk about what a combined medical and behavioral intervention might look like. What are the target behaviors that we want to track? How are we going to operationalize the target behaviors that we're going to track? And then how are we going to track them? And then how track them? And then how often can you get that data to me? So that we can evaluate whether or not the recommendations that we're making are having the effect that we want them to have. Also included in the model, nursing, care navigation, social work, and clinical psych, especially for the treatment of the growing incidence of anxiety, OCD, and depressive symptoms. And so we have clinical psychs working on here too. So it's an interdisciplinary team approach, ideally within a medical model where the incentive is already in place to use the behavioral support services and the other services available to you to get a higher reimbursement rate with the addition of, with the data that supports that. And the goal would be to not only have a comprehensive treatment package, but a more comprehensive case consultation approach. Bring in an interdisciplinary team. And so we're doing that. We're doing that with mental health providers across the Eastern region. We've done it with Hall Mercer. We've done it with Horizon House, 2 mental health provider agencies in Philadelphia. We would like to expand those services with our friends at St. Chris and Renee because many of these kids are behaviorally complicated and medically fragile. And it's really, really important to get the assessment process identified that you're going to use to diagnose not only the autism spectrum disorder, if not on spectrum, but also the comorbid diagnosis, intellectual disability or no intellectual disability, mental health issues around the occurrence of things like anxiety, depression, OCD, and then with that interdisciplinary team, think about a comprehensive holistic treatment approach that includes all these other disciplines: physical health, mental health, behavioral health, pharmacological, and then care navigation. And so that's what this team is comprised of. And we've been doing this for about 1.5 years now, and it's taken different turns. It's sort of growing on its own in ways that I had not planned. CBH would like us to think about expanding this into a clinic at the Autism Institute. Probably not something that we're prepared to do. But what we're thinking about is how is this approach going to naturally progress? What are the multiple iterations going to look like? Can we follow those trails of these multiple iterations in a way that allows us to set up a statewide approach for this? Our goals: comprehensive case conceptualization for complex cases, evidence-based therapeutic approaches, and build internal capacity. The goal would be to build internal capacity in all the providers that we're working with, because that's where the sustainability is going to be, right? That's where the maintenance and sustainability is going to be. So these are the folks that we have working on this team with us. You will hear the terms board certified behavior analyst and behavior support consultant. They are not the same thing. A behavior support consultant may be a board certified behavior analyst, and they may not be a board certified behavior analyst. And I think this is a very important distinction to make. Behavior analysts, folks like me, look at behavior in a very different way. It's an ecological approach to the identification of the environmental arrangements that occasion behavior. So we don't start with pathology. We start with ecology. What are the environmental arrangements that occasion behavior? And if you do that within a medical model and with a physician, then you're looking at both. How is this behavior learned, and what part of this behavior is biological or physiological? And that leads to a more comprehensive treatment package. Here's the process that we go through. I'm happy to respond to those questions about those later, but it's usually a 2-hour process that includes a complex case review, reason for referral. We investigate types of supports. We do record review, previous evaluations, previous interventions. It's a full review of ADLs, work, behavioral health, med management, daily activities. We think it's a very holistic approach. Ted's going to talk a little bit more about the presentation of ASD. Are you there, Ted?
He's muted.
Ted, are you muted? A little bit louder.
Hello?
Yeah, good.
Okay. So tell me when you're ready for me to start.
So next up is Ted Brocken. So Ted has been our... I know. Is that funny? I missed something. I'm missing that social cue. Ted is he's our psychiatrist. He's a Penn psychiatrist. And Ted has been a part of this project from its inception. It's imperative that the medical community is part of this process. And for the adult population, many of them are seen by psychiatrists. And Ted's support with this project has been invaluable as we've gone through the multiple iterations and have moved in different directions along the way. So Ted, it's on you.
Okay, thanks. Can you hear me okay now? Okay, great, thanks. Thank you, Jim. I just want to second what Jim said. I think Jim did a terrific job of highlighting the huge need for adolescents transitioning to adulthood on the autism spectrum, and really the lack of services. But I just wanted to add to what Jim was saying, that the ASERT project and Drexel and Penn and others are really trying to make efforts to address this need. So this interdisciplinary case conference approach and consultation approach that Jim mentioned is really important. I've learned a lot from him, and at Penn I've started a adult autism spectrum program in which we do consultations for adults on the autism spectrum, and we're hoping to develop some more services aimed at improving social functioning for adults on the autism spectrum, and have worked together closely with Jim on this, and so we're really trying to address this. So I'm going to try to keep my comments relatively brief, so to try to leave time for questions at the end. So I'm going to sort of go fairly quickly through some of these slides. Why don't we go to the next slide? I'd like to sort of just bring a little bit of biological, genetic, medical perspective and neuroscience perspective into this, because there's a lot of active research going on in this area that may well inform in the near future how adolescents and adults and kids, for that matter, on the autism spectrum are treated medically. So one of the issues that came up is this rising diagnosis rate, this dramatically rising diagnosis rate in autism. And this sort of $64,000 question is, what's the cause of autism spectrum disorders? And one thing that's really important to keep in mind with ASD is that it's really not one disorder per se. I mean, it's defined as one disorder in the DSM-5, the Diagnostic and Statistical Manual of Psychiatric Disorders. But if you look at it from a biological standpoint and from a biological etiology standpoint, there seem to be many genes, perhaps hundreds of genes, and probably many environmental factors, all of which contribute in a complex way to the cause of autism spectrum disorders. And there's a lot of research going on in this area, and we're learning a lot about it. This slide shows a sort of breakdown of this. And the bottom line at the bottom there is, for the majority of cases of ASD, we don't really know for sure what causes it at a biological level. There are very rare causes of ASD due to certain prenatal infections or teratogens, and a minority of cases of ASD, about 10%, are attributable to known genetic syndromes, single gene syndromes, and I'll mention a few of those. Next slide. So there are some rare causes of ASD. Prenatal teratogens like thalidomide, valproic acid, and misoprostol are associated with increased risk for ASD. So valproic acid, Depakote, has been shown in some studies to raise the risk of ASD in offspring, in children, by about 7 times. And there are certain prenatal infections like prenatal rubella, Haemophilus influenza, and cytomegalovirus. Those are more rare now with immunization of pregnant women, but they've been associated with ASD. But if you look at ASD as a whole, these known environmental insults account for a very small percentage of ASD. Next slide. Actually, you can skip 2 slides. I'm going to get back in a minute to some of the genetic underpinnings of ASD. I think you can hit forward again on that slide, because, yeah, there you go. What do we know about the brain basis of ASD? Actually, not a tremendous amount yet. And what we know that's really well replicated is fairly crude. We know from many studies seem to indicate that there is an enlargement overall in the brain size in ASD. It's about 5% enlarged. It appears as if this isn't present at birth, but in the first few years of life, there seems to be an acceleration in the growth of the brain, so that by toddlerhood or by early childhood, the brain seems to be enlarged about 5% overall, with a somewhat disproportionate enlargement of the white matter of the brain. Next slide. There have also been a number, I'm summarizing an awful lot of research studies here really quickly, but there have been a number of functional MRI studies of individuals on the autism spectrum looking at how their brains function differently and how different circuitry within the brain is differentially activated in individuals on the autism spectrum versus typically developing individuals. And there's a lot of evidence indicating that certain areas of the brain that are involved in processing social and emotional cues.
Oh no. No.
Can you still hear me now?
Yeah, we're good. We just lost you for a minute.
Okay. Okay, I was just saying that there's a number of studies indicating that areas of the brain involved in processing social and emotional cues, such as the fusiform face area, which is part of the temporal lobe, and the amygdala, are activated somewhat differently in individuals on the autism spectrum. So there's a thought that some of these different activation patterns of certain brain circuits might underlie some of the social and communication symptoms in autism. Getting back to these etiological factors, if you go to the next slide, other environmental factors, what might other environmental factors be other than these prenatal teratogens? There's a number of studies that have indicated that increased paternal age, and I think there was one that was mentioned on NPR this morning about both increased maternal and paternal age that actually came out of research at Drexel, Jim's institution. So those seem to be risk factors for ASD. And there's just a whole host of other possible environmental exposures that people are looking into, including Craig Newshafer at Drexel. So if you go to the next slide, there was a recent study on traffic-related air pollution, and that individuals in areas with higher levels of traffic-related air pollution may have higher rates of ASD. That's just one example. There are probably many of these. And you always have to be a little bit cautious about these because the studies need to be replicated before we feel really confident in them. But there certainly does seem to be an environmental component to risk for ASD. Next slide. Yeah, you can keep hitting that till the whole list comes down. Yeah, thanks. So we're not going to really have time to go through these in great detail, I don't think. But the point of this slide is just to say that about 10% or so of cases of individuals with ASD, the behavioral symptoms can be attributed to one of several known genetic syndromes. One of the most common ones among these is Fragile X syndrome, although that only accounts for about 1 to 3% of cases of ASD. Other known syndromes include Rett syndrome, which is really almost exclusively seen in girls, Turner syndrome, tuberous sclerosis, duplications of the 15q11 to 13 area of chromosome 15. So the point of this slide is really just to say that when you evaluate someone with ASD and you think they may have ASD, or you send them for an evaluation, there's really a multidisciplinary evaluation that's involved, including behavioral, psychological evaluation, medical evaluation, often in children, hearing assessment, and so on. And another part of the evaluation that's should probably be included in almost all cases is or at least offered, is a genetic evaluation to determine whether they have one of these genetic syndromes. Because in addition to the behavioral symptoms, there can also be medical implications of having some of these syndromes. So I think I'm going to, in the interest of time, go really quickly through some of these. Syndrome, as I mentioned, is probably the main one, the most common one to keep in mind. Accounts for 1 to 3% of cases of ASD, although not everyone with Fragile X has ASD. Next slide. Some of the symptoms include intellectual disability, autistic-like features and social anxiety, sleep disorders, seizures, long, narrow faces with large ears, and so on. That's Fragile X syndrome. Next slide. Maternally inherited duplications of this 15q11 to q13 region have been associated with autism. It's interesting that it's specifically when it comes from the mother, because there's probably some imprinted genes in that area. And now you can skip 2 slides to the other disorders, just for the sake of time. So the point of that is just to say that it's worth thinking about some genetic syndromes and a genetic evaluation in individuals with ASD, and it may inform their care as they go through the medical system. Another thing that's important, especially with adults, late adolescents or adults who have not previously been diagnosed with ASD, is to think about differential diagnosis or other disorders, other psychiatric disorders with symptoms that may overlap with ASD, which might include, in particular, schizophrenia and the negative symptoms of schizophrenia, and I'll say more about that in a moment, or schizophrenia spectrum disorders. When people talk about the symptoms of schizophrenia, they often divide them into the so-called positive symptoms, which is basically the presence of behavioral symptoms that are not typically there, like hallucinations or delusions, psychotic symptoms, and then the negative symptoms, which are the lack of certain kinds of behaviors that are there in typically developing individuals, which include social interaction and other kinds of motivation. So this kind of social withdrawal can be seen as part of the negative symptoms of schizophrenia. So one thing that comes up clinically is differentiating in an adult who is socially withdrawn or has few friends and few social contacts. Could this be schizophrenia? Could this be autism? How do you really go about differentiating the two? And this is something that we've come across in our research, and we come across clinically, even in these case consultations that Jim was mentioning. Next slide. So Jim mentioned this study at Norristown State Hospital that I was a part of, along with David Mandel and others. And some of the ways, we looked at some of the factors that might help differentiate ASD in adult versus schizophrenia, and I've listed a few of them here. Probably the key one is getting a developmental history and determining the onset of symptoms. By definition, ASD is an early onset, early developmental disorder, as I'm sure you all know. So the onset of symptoms should occur by 3 years of age, and it should be diagnosable, although not always diagnosed, by about 3 years of age. Whereas with schizophrenia, the onset of symptoms is typically in adolescence or adulthood. There are sort of rare forms of childhood onset schizophrenia. It's very rare, and that typically starts later in childhood, probably not much earlier than about 7 or 8 years of age. So with ASD, it's an earlier age of onset. In ASD, the most prominent symptoms are social withdrawal and restricted repetitive behaviors that are not driven by clear-cut hallucinations or delusions, whereas in schizophrenia there typically are overt hallucinations or delusions. Smoking is an interesting differentiating factor. It's not absolutely perfectly differentiating, but smoking is extremely common in individuals with schizophrenia, and at least by the data in our study in Norristown, was much less common in individuals on the autism spectrum. Also, kind of a criminal history or history of trouble with the law is more common in individuals with schizophrenia than in ASD. Intellectual disability is more common in folks on the autism spectrum than in schizophrenia. Next slide. So I'm going to say a little bit about medical treatment of ASD. As Jim mentioned, I think it's important to emphasize that a couple of things. One is there's really no medicine per se that can address all of the symptoms of ASD. And even though I'm a medical doctor and a psychiatrist, I really think that the core treatment of individuals on the autism spectrum is behavioral. And I see medications probably as more of an adjunctive role. I mean, they can be extremely helpful in some situations, but medications really are best used as part of an overall treatment plan that includes a behavioral component. So when I think about using medications in individuals on the autism spectrum, it's important, of course, especially with adults, to verify the diagnosis, to differentiate autism versus schizophrenia. High doses of antipsychotics are not going to typically help the restricted repetitive behaviors of ASD or other core features. As I mentioned, meds should be used as part of a comprehensive treatment plan. But there are associated symptoms that go along with, that are present in many individuals on the autism spectrum, like depression and anxiety, that can respond well to medications. Next slide. As I alluded to, there are some limits of the currently available pharmacologic agents for treatment of autism. In terms of the social behavior symptoms and the language and communication impairments in autism, there's really no good medication to address those core features of autism. And that's why behavioral interventions are so important. Next slide. So what can medications be useful for in individuals with ASD? I sort of broke down a few examples here. One is interfering repetitive behaviors, things like repetitive motor mannerisms and sort of obsessive compulsive like symptoms may be responsive to serotonin reuptake inhibitors, although we still need more rigorous studies in that area. And I should also emphasize that the really rigorous evidence base with randomized controlled trials and so on is quite limited for adults with autism. So a lot of these medications are used in an off-label manner, and we really need a better evidence base for the use of these medications. Irritability and aggression, impulsive aggression, severe temper tantrums, self-injurious behaviors. Typically, the medication class that's used to address those in individuals with ASD are the antipsychotics. And risperidone and aripiprazole or Abilify are FDA approved for use for some of these impulsive aggressive tantrum-like behaviors. As Jim mentioned, though, it's important to mention that there are excellent behavioral interventions as well. So I think the best way to approach these is in coordinating care between a behavioral and a pharmacologic approach and working together on that. Hyperactivity and inattention, some of the ADHD medications like stimulants or non-stimulant ADHD medications can be useful. If there's comorbid depression, antidepressants like the SSRIs or selective serotonin reuptake inhibitors can be useful. Also for anxiety-related symptoms they can. And if they're comorbid seizure disorder, of course, anti-epileptic medications can be useful as well. So I had a bunch of other slides here going through the particular medications and a little bit more details on them, but I think to leave time for questions, I don't think that may be the most useful use of our time. If you might be able to skip way ahead to sort of like the third to the last of my slide that says purposes of non-pharmacologic treatment. Is that possible? Keep going. You're going to skip a bunch of them.
Yeah, Ted, can you roll through these slides quickly?
I'm sorry, I can't hear you. Was that Jim?
Yeah, he's asking if you can kind of. Oh wow, that's weird. Go through them maybe quickly.
Okay, go through the meds quickly. Okay, sure. So yes, all right. So meds used in ASD. So as I mentioned, risperidone and aripiprazole and some of the other antipsychotics can be helpful in minimizing aggressive and self-injurious behaviors. The SSRIs, selective serotonin reuptake inhibitors, can be helpful for depression or anxiety. I mean, just as they can be helpful in typically developing individuals. I think the jury is out on how helpful or the degree to which SSRIs are helpful for repetitive behaviors. There's some conflicting data on that in the literature, and some of those conflicting data may be due to the fact that ASD is so heterogeneous, as I mentioned, that not every individual with ASD is the same. And so there may be, some of this is in a case-by-case basis. There may be some individuals who really are helped by SSRIs, and there may be others who are non-responders. Methylphenidate or atomoxetine or Strattera, the ADHD medications, can be helpful for some of the hyperactivity symptoms. And as I mentioned, the anti-epileptic drugs can be helpful in treating seizures, and are sometimes used for maladaptive behaviors like irritability. Next slide. So the serotonin reuptake inhibitors, so I'm just going to touch on each of these medication classes in a little bit more detail quickly. The selective serotonin reuptake inhibitors like fluoxetine, escitalopram, fluvoxamine are often used to try to target interfering repetitive behaviors like repetitive motor mannerisms and flexible adherence to non-functional routines or rituals, sort of OCD or obsessive compulsive like behaviors, repetitive ordering, hoarding, telling or asking, touching, tapping, rubbing. Sometimes the decision about whether to use a medication for these is really a matter of how interfering they really are. If these symptoms are sort of markedly interfering with the functioning of the individual in an educational setting or occupational setting or social setting, that may inform whether a physician wants to consider using medications. Next slide. The antipsychotics, as I mentioned, risperidone and aripiprazole and some of the other antipsychotics. In the olden days, haloperidol was used more often. More recently, people have gone more towards the newer antipsychotics like risperidone and aripiprazole. And they are typically used to target severe irritability, tantrums, aggression, that really is very interfering and making it either a risk for the individual or those around them, or interfering with their ability to function, as I mentioned, in a variety of settings. These medications may also reduce some of the stereotypies and hyperactivity in some individuals with autism, but of course you have to keep in mind the possible adverse effects of antipsychotics, including weight gain, sedation, etc., extrapyramidal symptoms. Next slide. Okay, the next slide is the ADHD medications, which would include methylphenidate, atomoxetine, clonidine, and sometimes guanfacine. These medications are used to target hyperactivity and inattention, sort of ADHD or attention deficit hyperactivity disorder types of symptoms that sometimes go along with ASD. I should note, though, that children with ASD tend to be somewhat less responsive to these medications than typically developing individuals who just have ADHD without ASD. So they tend, only about 50% of patients on the autism spectrum tend to respond or much to these medications. And these medications are also somewhat more likely to have adverse effects in individuals with ASD than they would in just sort of straight ADHD patients. So, for example, irritability is one of them. Next slide. Okay, so valproate. Valproate, there's less of an evidence base even for the use of this medication, but it's sometimes used to target irritability, affective instability, sort of mood instability, impulsivity, and aggression. But the results, if you look at the literature, are somewhat more inconsistent. And so that next slide, treating social and communication disability. So as I mentioned, there really are not medications at this point. I mean, there's a lot of research going on to try to develop new medications that might effectively target these areas. But right now, the main way to address the social and communication disabilities, some of the core features of ASD, are through non-pharmacologic treatments. Next slide. So when you think about things like building skills in individuals with autism, like building social skills or building language and communication skills, that's where non-pharmacologic or behavioral treatment approaches become so important. And as Jim mentioned, the behavioral approaches really can be used in conjunction with pharmacologic approaches to address some of these interfering aggressive behaviors and so on. So, for example, as Jim mentioned, often in our multidisciplinary case consultation work, we found that some of these distressing, aggressive, or self-injurious behaviors seem to be either because or exacerbated by the fact that the individuals don't have a good way to communicate, or to functionally communicate. And if they can't communicate their needs well, they become frustrated and aggression sometimes becomes the way to communicate their needs. And so by really looking at this carefully with a behavioral approach, that can help quite a bit. And sometimes medications are needed to deal with an acute situation or subacutely, but over time as a behavior, our approach is that as some of these behavioral interventions take effect, that either lower doses of medications might be needed, or perhaps eventually the medications could even, some of them could be discontinued. Next slide. So this slide just sort of breaks down the overall treatment goals for individuals on the autism spectrum into, on the left-hand column, skill acquisition, and then in that right-hand column, behavioral reduction. So I think, both a pharmacologic and behavioral approaches can be helpful for the behavior reduction, so the reduction of sort of interfering behaviors. But for skill acquisition, we need non-pharmacologic approaches. So it's really been a pleasure to be part of this ASERT team and this interdisciplinary approach, and Jim and I really hope to continue our work together and disseminating this through the state. So I think I'll stop there, and then we can take some questions.